Thank you very much. I'm sorry I wasn't here on time. I was working on the slides to get them ready for later on. This is a very interesting subject, type A and type B dissections. I alluded to this a little bit when I was speaking a few minutes ago. Just about the classification, so we all understand, we have two classifications, the Stanford and the DeBakey. Coming from Houston and trained there and been there as a professor associate, I usually go by DeBakey, but today we'll probably go both ways. Clear, the more difficult aneurysms are those that are extensive. The Stanford B and DeBakey type 3 or type 3B if it goes below the diaphragm. Now there's a significant difference in how we treat these, type A and type B decisions and treatment. And we have to know whether we have a stable condition or an unstable condition, asymptomatic or symptomatic, no vascular compromise or vascular compromise, and whether it's stable and expanding as in a chronic aneurysm. So all this has to be taken into consideration. Type A historically has been treated with the medical, surgical treatment. Medical treatment for a type A has not been very successful. However, if you look at type B, I put some question marks here because as I go on in the talk, you're going to see that I think a pattern is changing. Surgical repair for type A is mandatory and is probably still the gold standard, but I'm going to challenge that for type B. Endovascular approaches for type A, I'll show you not a lot of good results there. Very good results, I think, in descending. And then we have the hybrid approaches. Now, one of the problems, of course, in dissection is the landing zones. We have a short deployment area. There is a curvature, which is a problem. We have oftentimes different diameters in the ascending and descending. And for those of you who are cardiac surgeons, you know that the tissue is extremely friable. And there are no commercial products. This requires customization for the ascending. Here's a very good example of a case that we were able to do acutely. This patient had a hematoma forming. You can see that out here on the side, out here. But the patient was reasonably stable, and so we were able to put together a customized graft, and we did deploy that, and you can see 24 hours later, it looks very satisfactory. Bring the graft right down to the coronary arteries. Now, as we get into the ascending itself, this becomes much more complicated because you can see here we have the sinus of Valsalva. This is a typical sinus of Valsalva aneurysm. When these dissect and have aortic insufficiency, there's really no endovascular possibility for that in the current arena. Now, type B dissections have classically been treated with medical treatment, and there's been no indication to treat an uncomplicated type B thoracic aortic dissection. And the reason for this is the INSTEAD trial, Professor Nienaber and Rostek, this trial, which you all know about, at the end of 365 days, there was no difference whether they treated with an endoluminal graft or if they treated it with medicines. Quite frankly, I knew at this time this was a flawed study, and the 5-year data, which we'll come back to in a moment. And the reason I think it's a flawed study is the major reason for these patients to die after a type B dissection is late rupture, and occurs in about 60% of the patients. Here's a very nice example. This patient here, you see there's good, well, look here first. True and false lumen about the same size. What happens in this patient, though, this false channel enlarges, and this is where the rupture occurs. This is another nice example. This patient came in, was treated with medicines. 3 months later, came back in, acute pain, creatinine 3, absent femoral pulses, and you can see what happened here. The true lumen has been compressed all the way down here to almost no flow, and the false lumen expanding. So this is a question I asked and debated Dr. Nienaber several years ago. Doesn't it make sense then, with the emergence of endoluminal technology, to treat acutely the etiologic factor that causes rupture and eventually death? And what is that? That's the intimal tear. So medical therapy for acute aortic dissection probably is a poor insurance policy. It's unpredictable in causing the thrombosis of the false lumen. You saw examples of those false lumen increasing. No assurance of long-term stabilization to prevent rupture or dissection. Expansion of the true lumen is an active process with endoluminal graft technology. You get formation of thrombus in the false lumen. That's a passive process, so A plus B mimics the natural healing process. Well, Dr. Rodriguez and my group put together a study a few years ago, and this study was published in June of 2008 in the Journal of Vascular Surgery. And what he did was he looked at the location of the tear in the descending thoracic aneurysms, and they studied the behavior of the dissection, the diameter at these various levels, the flow in the true and false lumen, the pattern of thrombosis formation, and aortic flow patterns in the lumen. And then they developed this ratio of the false lumen, true lumen. They call this an index. And what they found from this, in following the patients, there were 40 patients in the study, 78% were followed. At the end of 453 days, the stability occurred in 22 of 31, regression in 8 of 31, and expansion of 1 of 31. The proximal site was closed in all 29, and you're going to see why that's important in a moment. The lumen thrombosis, complete thrombosis, were 19 of 29, 12 stable, 7 regression, only 1 patient expanded. So the observations here were successful treatment of a proximal entry tear effectively resulted in complete obliteration of anterior antegrade flow. Antegrade flow does seem to be the main source for aneurysm dilatation by expanding retrograde, the false lumen, and successful resolution of antegrade flow creates thrombosis for proximal thrombosis lumen in immediate postoperative period. So this, I think, brings up the challenging change of pattern, and I think the pendulum is now swung. These are the original NSTED data at a year, followed out at 2 years, and now the latest study reported at ICON, our meeting just a few months ago, the 5-year data. And look at what the 5-year data show. Freedom from progressive aortic disease only in TEVAR, not in medical treatment. Freedom from aortic-related mortality, same, TEVAR favored. And the cumulative overall medical therapy, TEVAR wins in every one of these. So I think it's fair to say, and this is actually Ian Eber's summary, uncomplicated type B dissection is not stable and medical management is not safe. Isolation of the false lumen leads to remodeling to avoid new acute scenarios. Successful remodeling, usually completed after 2 years, ensures long-term stability, and preemptive TEVAR in type B dissection sets the stage for remodeling and may become the first line of therapy. Even the expert consensus now from the group of thoracic surgeons agrees with this. They think the pendulum has swung. Instead, the long-term study encourages stent graft-induced remodeling in any type of type B dissection. So I think, ladies and gentlemen, we have seen over the last few years a complete change in our philosophy about treating type B dissections, even if they're not uncomplicated. I think the new gold standard is endoluminal graft deployment. Thank you very much. No questions.
Okay.
Dr. Dietrich, has anything changed in type A? Is it still only surgical, or are there anything new coming there?
Acute type A today, I think, is surgical 99.9% of the time. We may have 2 cases in our whole series where the patient was stable and for medical reasons was not really a very good operative candidate. But we don't have the technology for it yet. We don't have the proper grafts. We don't have, every time we do something, it has to be customized. Fixation is a problem. So we just don't have the technology. It's coming. We're going to have it. There's no question about it. But right now, almost all these patients are taken care of with a open repair. Later on in my next talk, I'm going to talk about some new technology that we're introducing that I think may have an opportunity to do this. Thank you very much.